And then I have my colleague Allison, who is doing the back end stuff. So she'll be monitoring the chat and doing slides for me. So thank you, Allison. So let's go ahead and get started. Thank you all for being here. Today's topic is on how diet and exercise impact cancer risk. And we have our colleagues, Dr. Mary Pladen and Dr. Adriana Coletta, with us as presenters. So thank you all for being here. Next slide. Awesome. So here is our agenda. I will just take a few minutes to set the stage, and then I will pass it over to Dr. Pladen, who is going to talk a little bit about the impact of diet and cancer risk and management. And then afterwards, Dr. Coletta, who will talk about physical activity and cancer. And then we will close out with any questions, closing remarks, and then a few poll questions on your experience today on this webinar. Awesome. So for those who may be new with us here today, just a little bit of background information to set the stage on Huntsman Cancer Institute. So we work primarily serving the Mountain West. We are the only designated National Cancer Institute, comprehensive cancer center in the region. In 2021, we formalized our commitment to the five-state Mountain West, so we serve 5 different states, including Idaho, Montana, Nevada, Utah, and Wyoming. Huntsman serves the largest land area by any National Cancer Institute, and we serve 17% of the contiguous U.S. landmass. So we serve a lot of people in a lot of states, so I'm doing a lot of great work in the area that we serve. Next slide. So this webinar and the Mountain West Cancer Collaborative comes out of the Office of Community Outreach and Engagement at Huntsman Cancer Institute. The mission that we have is to collaborate with community partners, patients, advocates, clinicians, researchers, and students to address the unique cancer-related challenges across the Mountain West. As I mentioned, we serve the 5 states listed here, and then our focus areas include building partnerships with community-based organizations, enhancing community awareness and education, improving access to care, and driving long-term data-driven solutions. And then moving to partnering with communities. So our office, the Community Outreach Engagement or COE office, connects research, care, and communities across the Mountain West. And we really want to center our work on listening first to community voices. So we do research focus groups to make sure that we include the communities that we are working with, building trust through consistent presence and partnerships, and supporting community-led approaches to prevention, education, and care. And then about the Mountain West Cancer Collaborative. So if you have not joined yet, we invite you to join us. We are a multi-state network that is convened by the COE office at HCI, and we support community-facing partners across the 5 states. Here are some things that we offer. So peer learning and best practice sharing, alignment around rural cancer priorities, working groups to elevate local expertise. So we have a monthly newsletter that we send out. We have our quarterly webinar series like this one, and then we also have ad hoc action groups that we invite you all to join as well. And then these are the objectives for today for this webinar. So first are to increase knowledge of evidence-based lifestyle strategies, translate research into practice, and highlight innovative research initiatives at Huntsman Cancer Institute. Great. So to introduce Dr. Pladen, I'm just going to give a brief introduction and then pass it over to her. So Dr. Pladen is a nutritional and cancer epidemiologist. The overall goal of her research is to understand the role of diet and obesity in the development and prognosis of cancer. Dr. Pladen is interested in unraveling the metabolic factors underlying dietary relationships with cancer, using metabolomics and developing dietary biomarkers to better measure diet. She earned her PhD in chronic disease epidemiology from Yale University. So Dr. Pladen, I will pass it over to you.
Thank you. Do you mind actually if I share my screen because it'll be easier to advance?
Yes.
Thank you.
I think you should be able to. There we
Are
go.
you looking at my presentation screen?
Yes.
Okay, great. Thank you so much for having me. So I'm going to give you just a brief, I have 20 minutes, so I'm going to try to be quick and give you a brief snapshot on diet and cancer. So I'll just quickly tell you a little bit about my story and why I care about this work, and then just really dive right into what does the science say about diet and cancer. I'm going to focus on cancer prevention and then diet during and after treatment as well, and then just end with a little bit of what we're doing in our research group to study diet and cancer. So I actually started my research journey as a research dietitian, and I worked with cancer survivors, breast cancer survivors actually, on diet intervention trials. And that's what really motivated me to get my PhD in nutrition and cancer. Kind of at the same time, my mom got diagnosed with late stage ovarian cancer. And we subsequently learned that many members of my family have the BRCA2 gene mutation. So that puts a lot of family members at higher risk of a number of different cancers. And so this kind of reinforced my passion for this field. It's very important to me, and something that I learned working with hundreds of breast cancer survivors as a dietitian, and also obviously with my mom, is that one of the first things that patients ask about is, what should I eat? And so that, is really the foundation for what we do. We want to be able to inform people that have high risk families. We want to be able to inform the general public, and then we want to be able to advise our cancer patients on what to eat. So what does the science say? So I want to draw your attention to the American Institute for Cancer Research and the World Cancer Research Fund, which is an organization, kind of a collaborative organization with the US and Europe, that together do these really deep dives and enormous reviews on the current status of the evidence on diet, physical activity, and cancer. So you can find basically the most comprehensive information that we have to date on the topics of different foods, different dietary patterns, exercise, in relation to different cancer types, online, dietandcancerreport.org. So I recommend that you visit that website to get up-to-date information. They have a continuous update project, so they're continually updating because the science is continually being updated. So I don't expect you to read all of these bubbles, but on the website, they have a nice interactive feature that shows you the level of scientific evidence for the relationships between diet, physical activity, and cancer. So you don't have to be able to read it, but I'll just draw your attention to the images. The green circles represent lifestyle factors that show convincing or probable links to having lower risk of cancer, and then the red represents lifestyle factors that have convincing or probable evidence for higher risk of cancer. And then the size of the bubbles represents the amount of data or the confidence that we have in those findings, kind of like the quality and amount of evidence on that topic. So here I really cut off the convincing and probable. There's a whole lot of levels of evidence in between, but this is just kind of synthesizing some of the key points. And you can kind of see some things start to stand out, like really physical activity that Dr. Coletta is going to touch on is very, very important for cancer prevention, for preventing weight gain. Weight gain is, being linked with obesity, which is a risk factor for at least 13 different types of cancer. And then other factors that kind of stand out are especially dietary factors linked to gastrointestinal cancers. And these are things that kind of touch the gastrointestinal system from when you put it in your mouth all the way through. So things like maximizing the fiber in your diet through fruits, vegetables, and whole grains is protective of gastrointestinal cancers. And then on the flip side, you can see that certain factors linked with kind of more of a Western dietary pattern, things like processed meat and sugar sweetened beverages have been linked with potentially with high risk of some cancers and with weight gain and obesity. So those are kind of things that stand out in the evidence. So I mentioned achieving and maintaining a healthy body weight is really important. because now we know that excess body weight is linked with at least 13 different cancers. And so the things that we have evidence on that contribute to this challenging area are kind of what I mentioned as well. So fiber, following a dietary pattern that's high in whole grains, fruits, vegetables, legumes, kind of like a Mediterranean dietary pattern has been shown to be protective. And then limiting things like fast food, sugar sweetened drinks, and also screen time. There's a lot of evidence showing screen time being linked with obesity. So those are important things for obesity prevention and hence cancer prevention. But I want to focus on some myths and facts that cancer patients tend to ask about. So one of them is alcohol. So let's focus on this question. Can I drink alcohol if I'm wanting to prevent cancer? So what the WCRF report says is that up to 2 drinks a day, has been shown in the past to potentially be protective against some cardiovascular diseases, but it can increase risk of a number of cancers at this point, including gastrointestinal cancers, breast cancer, postmenopausal breast cancer. And so for that reason, it's recommended to limit intake as much as possible. Should I load up on antioxidants? So these are things that have high levels of vitamin C, vitamin E, and carotenoids, which are things that give fruit and vegetables the vibrant colors. These are plant chemicals that help prevent DNA damage, so they can help prevent cancer through, maintaining the integrity of your DNA. And since cancer survivors may also be at risk of second cancers, filling up on antioxidant-rich foods is also a goal for cancer survivors. And so you might hear the old adage, like, eat the rainbow, and that's actually really good advice. So if you're making a salad, try to make it as colorful as you can, because that's going to maximize the amount of antioxidant and other kind of phytochemical nutrients that your body is exposed to. So the more color, the better. Another question we often get is, do you have to worry about dietary fat? So this was a controversial topic for many years, especially, research that looked at dietary fat and breast cancer. There isn't strong evidence to restrict overall fat per se, but at this point, we have accumulating evidence that the type of fat might matter. And this is similar advice to what we get for preventing cardiovascular disease and, preventing or managing diabetes. So really not worrying as much about amount, but really focusing on type of fat. So trying to avoid saturated fat, which comes in animal products. So things like cutting the fat off meat, taking the chicken off skin, and really focusing on plant-based sources. So, and also fish oils are good as well. So focusing on things like avocado and other olive oils and certain plant-based oils. I mentioned fiber, so clearly it's an important protective factor for prevention of a number of different cancers, especially cancers of the gastrointestinal system, like colorectal cancer. So that in terms of, after a cancer diagnosis, there's not as much evidence specifically, but certainly for prevention of cancer and prevention of second cancers. A lot of health benefits linked with dietary fiber. So choosing whole grains, choosing things like brown rice, bread, pasta, keeping the skin on fruits and vegetables as best as you can is going to give you a lot more fiber. So you get a controversial information from the media. So, we see different types of messages on meat intake, for example. So a question we often get is, can I eat meat? Right now I'm talking about cancer prevention. So studies have linked red and processed meat. So processed meat being things like, bacon, hot dogs, and deli meats, with risk of some cancers, like cancers of the colon and rectum. And there are different reasons for that. For example, if you grill things at high temperatures and you get that yummy char grilled meat, that can actually be carcinogenic. And then, some of the preservatives in processed meat are negative. So rather trying to focus on non-red meat protein is a goal in terms of cancer prevention, especially things like poultry, fish, and legumes, so beans, lentils, things like that. And here you can see some alternative sources to get your proteins. So you can get a little bit of protein in nuts. You get good protein in legumes, tofu, things like that. All right, just trying to speed through my slides because we have limited time. So what about soy? I think there have been messages in the media to avoid soy, especially for breast cancer, but the evidence actually doesn't say that. It doesn't say that soy is harmful in terms of cancer. So things like tofu are actually a great meat alternative. It's quite bland, so you can spice it up with anything. You can add sauces. You can grill it and add a satay sauce, for example. So you don't have to worry about soy foods. And then should I eat organic? This is also an important question, especially with the media recently. There's a lot of focus on herbicides and pesticides. And I think the research is still ongoing in that area. If you're concerned about it, you can choose to purchase organic, which tends to have, less pesticides and things like that. They tend to be more expensive. And I think the evidence showing that, fruit, vegetable, whole grain intake is cancer preventive. I think getting the fruits, vegetables, and grains is the most important thing. If you can buy organic, that's great. Otherwise, really scrub your fruits and vegetables. Things like strawberries, you can soak them in water with some baking soda to help pull out the remaining pesticides, for example. Like just washing them will get 80% off. And you soak it in some baking soda to pull out the rest. So you can wash things if you're concerned about those things. Does sugar feed cancer? This is another question we get. So sugar in and of itself does not necessarily feed cancer, but high intake of sugar sweetened beverages and added sugars as part of highly processed diets can lead to insulin resistance, and it can contribute to obesity. And those things are important in terms of being cancer risk factors. So I think, as long as you're getting your blood sugar levels monitored and trying to keep your blood sugar levels in the healthy range in general, then you can eat sugar-containing foods as part of a healthy diet. Just making sure that you're monitoring your metabolic health. And then fruits and vegetables in cans is totally fine. Just look for the sources that have less added sodium, especially. And if you're choosing fruits, try to get the canned fruits in water rather than syrup, for example. Coffee, there's mixed thoughts about coffee. Coffee is actually very high in antioxidants. It's insulin sensitizing, and it can help with metabolic risk factors, and it's actually been shown to be linked with lower risk of a number of cancers. So coffee is good. So don't worry about drinking Starbucks. So just switching to where should you get your health information, especially because the evidence is changing so rapidly all the time. It's important to remember that, especially social media, where we get a lot of our information these days, studies have shown that a third of popular social media articles that are directly talking about cancer prevention is actually misinformation. So it's really important not to believe everything you read on social media. Go to credible sources, things like the American Cancer Society, the American Institute for Cancer Research that has that updated report, the National Cancer Institute. We have excellent resources here in the Wellness Center at the Huntsman Cancer Institute, your healthcare provider. And then if you want specific dietary guidance, look for a certified specialist in oncology registered dietitian. So they'll have CSO at the end of their name. If you search on the Academy of Nutrition and Dietetics website to find a dietitian, you can look for CSO, and they're going to be specialized in oncology. So that's where to look for credible information. Just flipping very quickly, I think I'm almost at time, so I'll try to go quick. So diet during cancer treatment. This is just a summary of all the clinical trials that have been done on diet during cancer treatment. And basically the summary is we need more research. And so Dr. Coletta and myself, we're working in this area. We're trying to develop and implement trials to test different dietary strategies to improve outcomes in cancer patients. Because what we have so far, the studies have tended to be small, and they've looked at mostly outcomes like body weight and things that maybe not as clinical outcomes, more hard outcome endpoints, things like cancer recurrence, for example. Fewer studies have looked at those kind of outcomes. And so we need more research. But given that the standard medical nutrition therapy goals during cancer treatment, we want to deal with nutrient deficiencies. We want to prevent or reverse them, prevent malnutrition. You want to improve your tolerance to your treatment. There are a lot of side effects, so we want to help you give guidance on what to choose and what to avoid to manage the different symptoms that you get with your cancer treatment. We want you to keep the same weight as much as possible during your cancer treatment, not gaining too much, not losing too much. Just stay the same, focus on your nutritional status, avoiding malnutrition. We want you to, maintain as much of a quality of life as you can during treatment. And then ideally, if you can meet with a CSO dietitian earlier on in your treatment to get a personalized plan, that would be ideal. We worked with some nutrition and dietetic students. They developed some patient education materials on diet to manage different side effects of cancer treatment. And they're all up on the Huntsman Cancer Institute YouTube channel. So you can jump onto the YouTube channel and you can look them up. And there's linked resources for each video that you can download as well. I'm just going to skip that for time. This point, just to be that during cancer treatment, try to avoid dietary supplements as much as possible. It can interact with treatment. Unless there is a legitimate nutritional deficiency, then you can talk to your doctor about taking a vitamin. But most cancer patients take supplements, sometimes many supplements. Make sure you talk to your provider about that to make sure it's not interacting with anything in your treatment plan. And I'm just going to skip that. So treatment is done. What's next? Once you're past the treatment period, sometimes cancer patients feel, you're not seeing your oncologist as much. Sometimes patients think, okay, now what do I do? In terms of diet, the guidance is really just focus on the same guidelines I talked about for cancer prevention. So overall healthy eating, overall plant-based diet high in fiber, ideally. So the WCRF, the World Cancer Research Fund, American Institute for Cancer Research, that very first website I put up, they have a couple of specific guidelines for specific types of survivors of specific types of cancer. One of them is breast cancer. And they're slowly developing these guidelines that are targeted to cancer survivor populations. We're still developing the research. As I mentioned, there's a smaller number of trials that have been done in cancer patients. And so these reports are taking a while to come out, but they will catch up. But there are specific guidelines for things like breast cancer right now, for example. And then just to very quickly touch on my own research, because I think I'm at 20 minutes. My lab studies the interface of diet and obesity with human metabolism and cancer. So we really have a strong metabolism focus. We want to understand what aspects of metabolism drive the development of cancer and outcomes in cancer patients. And then how can we figure out dietary strategies to kind of pinpoint those pathways? And we use molecular approaches. So one big problem with dietary research is it's just very difficult because we rely on questionnaires and there's some measurement error with people, misrecalling what they eat because we ask, what did you eat over the last year, for example? It's hard to remember. And so a lot of my work has been to develop objective dietary biomarkers to help us to better measure diet. But then we can also better understand why a certain food or diet might be linked with cancer, because we can understand what's happening with your metabolism. And we can pick up what you eat, but we can also pick up even more food detail, like coffee biomarkers, for example. We can tell if you used light roast, medium roast, or dark roast beans. We can, pick up caffeine metabolites, other phenolic compounds that are beneficial, and then detail about the type of bean even in your coffee. And so on a questionnaire, typically we ask, do you drink coffee? But a tiny drop of blood can tell you exactly what bean you typically use in your coffee. So we get a lot more information, which is cool. So earlier research, we kind of looked at some of these food-related molecules in relation to breast cancer risk in these big cohort studies. And we kind of were able to pinpoint why has alcohol been linked with higher risk of postmenopausal breast cancer. And it really, you can see here, these funny looking chemicals, a lot of them are actually sex hormones linked with estrogen. And a lot of postmenopausal breast cancers are these kind of estrogen driven tumors. And so that alcohol is increasing production of these estrogenic metabolites to then potentially increase risk of cancer. So we can understand why this relationship is happening, but then it's also pinpointing very specific things, like maybe studies had shown that overall fat was not linked with breast cancer risk, but we're seeing like very specific types of fats, like this particular one down the bottom linked with full fat dairy intake, for example. So you can start to pinpoint, okay, what really might be important in terms of cancer development. And we're also studying whole dietary patterns. So dietary patterns that are linked with higher or lower insulin or higher or lower inflammation. And we've shown in data sets of 1 million people that these patterns of eating are linked with higher or lower risk of colorectal cancer. We've studied primarily. But what we see is that there are different patterns of eating, slightly different collections of foods that can have a positive or negative impact on your metabolism to affect cancer risk. And that's just, I'm hoping ultimately we'll be able to offer different strategies depending on your dietary preferences and choices for cancer prevention. So it's not like there's one diet for preventing cancer. There might be different ways of eating. It's just a matter of how you combine very specific kind of groups of foods together to affect your metabolism. And then this is just to show you that the gut microbiome is probably playing a predominant role, at least in the colorectal cancer diet relationships, because we found a lot of microbial metabolites being linked, kind of tying together the dietary patterns and the cancer. So your gut is very important. And just briefly touching on some interventions that we've completed, pilot interventions that we're kind of developing into larger studies at this point. Dr. Coletta and I are collaborating on a lifestyle-based intervention in bladder cancer patients. So what we did was we shipped boost boxes to patients, which included medically tailored meals and groceries to prevent malnutrition in bladder cancer patients getting surgery. And then Dr. Coletta's team gave precision resistance training guidance. And kind of the goal is, can we develop an intervention that helps to prevent malnutrition, that provides a level of, lifestyle education, and that can improve outcomes, after surgery, using this kind of framework of kind of like a HelloFresh style approach. And then another study that we completed, we looked at comparing different types of meal timing modification with healthy Polynesian diet in very specific populations here in Utah, Pacific Islanders at risk of cancer. And we worked with the Metabolic Kitchen to develop this yummy looking menu, which is Polynesian specific foods, balanced in nutrients for a healthy diet. And we kind of showed that both the meal timing modification, so when you eat, and being able to adhere to a culturally tailored healthy eating menu we showed improvements in metabolic health biomarkers, which are cancer risk factors. So that's just a snapshot of some trials that we worked on. And then this is my team. So thank you to my team. And I will hand it over to Adriana.
Thank you, Dr. Playton. That was great. I will just read over Dr. Coletta's bio real quick. And then if you do have any questions for Dr. Playton, you can put them in the chat. And then Dr. Playton, if you're able to look over that, if there's any questions, and at the end, if we do have time, we'll answer some questions as well. So Dr. Coletta's training experiences during her doctoral studies led her to pursue a career in cancer research and thus sought a postdoctoral training in cancer research. During her postdoc, she also completed training in behavioral science and exercise oncology. She now holds a dual appointment with the Huntsman Cancer Institute at the University of Utah in Cancer Control and Population Sciences program and the Department of Health and Kinesiology at the University of Utah. So, Dr. Coletta, let us know if you'd like us to share your slides or if you'd like to share them from your computer.
Thanks, Leslie. May I please share my slides?
Yes.
Awesome. Okay. I'm gonna share my screen. And then here comes the presentation. Can you see the presentation mode?
No.
Oh, okay. Here's why.
Oh, there we go.
And then, okay, there we go. How about now?
Yes.
Let me just move this over. Wonderful. Okay. All right, so thank you so much for the opportunity to be here today. I'm just going to talk about exercise for cancer prevention and survivorship. First, I'd like to just let everyone know a little bit more about what my group does. So we'll get started there. Our mission is to develop exercise and nutrition strategies that help people affected by cancer maintain or improve independence and quality of life throughout their care and beyond. And we like to leverage these strategies to complement cancer treatment. So we work primarily with folks on active treatment to help deliver a cancer-free frontier here at HCI. So what does that really mean? So that means exercise and nutrition clinical trials in folks during active treatment or across the care continuum, which is defined as after diagnosis, before, during, and after treatment. But again, we live mostly in the before and during space, before, after diagnosis, before treatment, and during treatment. And we want to help folks improve survival and look at changes in body function and conditioning and biomarkers linked with cancer risk and progression. I like to say we like to help folks survive and thrive. And some examples of the work we do and that we're doing right now is looking at creatine monohydrate supplementation and resistance training in men living with metastatic prostate cancer on active treatment. And then another work that we're doing is looking at a clinical workflow algorithm that aligns exercise and rehab services from time of diagnosis throughout care in women newly diagnosed with stage 1 to 3 breast cancer. And I'll focus more on that second study, the core trial, later. And I'm happy to answer questions about either examples at the end if we have time. But first, what do we know about exercise for cancer prevention? Well, we know that engagement in regular exercise reduces the risk of developing cancer, most cancer types. And here on this slide is 8 different cancer types where we have enough data to calculate your risk. And so for how you might read this, for example, is for colon cancer, you have a 24% reduction in risk of developing cancer should you choose to engage in regular exercise. So what does engagement in regular exercise mean? So this means adhering to the National Physical Activity Guidelines. What are those? That is engaging in moderate intensity aerobic exercise for at least 150 minutes per week. Or alternatively, vigorous intensity. So crank up that intensity, and then you can achieve this in half the time, 75 minutes per week. And then, of course, at least 2 days per week of strength training. That can be body weight training, using weights, using resistance bands, anything whole body to help strengthen those muscles. But what is moderate intensity aerobic exercise? I recommend folks to use what's called the talk test. So an easy way to measure moderate intensity exercise, you can talk while you're exercising, but you can't sing. An easy way to measure if you're engaging in vigorous intensity or that higher intensity exercise is if you can't say more than a few words while you're exercising. So this is the current recommendation for all folks for cancer prevention. What about survivorship? So now there's a cancer diagnosis in play. What do we know about exercise after diagnosis? So we know that there's evidence that exercise after a diagnosis can improve survival, both of mortality related to the cancer and then all-cause mortality afterwards. On this slide are the cancer types that have the most data to develop these relative risk scores. Breast, colorectal, and prostate are in bold and at the top of the table, just to indicate that there's the most data to support the benefits of exercise in these three cancer types. More research is needed in other cancer types. So if you don't see a cancer type on this slide, that doesn't necessarily mean that exercise isn't good. There's just not enough data to calculate these relative risks. So for breast, for example, how you would read this is you've got a 31% reduction in cancer-specific mortality, 41% reduction in all-cause mortality if you engage in exercise after a cancer diagnosis. To dig a little bit deeper in exercise programming and prescription, there's enough data available to develop exercise prescription. So how often you should do it per week, how hard you should work out, how long you should work out, and what type of exercise you should do for these different health outcomes that you see on the left. So there's strong evidence for fatigue, quality of life, function, anxiety, depression, and lymphedema. Strong evidence to support these different guidelines here if you were to do aerobic only, resistance, or a combo in your exercise routine, and moderate evidence that exercise at these specific guidelines on the table can improve bone health and sleep quality. Now, again, the most of this data is in breast, colon, and prostate cancer, but the other cancer types on the previous slide, there's also data from those types to help inform what you see on this slide. You can find this slide on the American College of Sports Medicine's website, and after I'm done presenting, I'll add a link to their Exercises Medicine Initiative, a Moving Through Cancer initiative, which will give you more information. So what are the recommendations for cancer survivors? So during treatment for aerobic exercise, that's 90 minutes per week of moderate intensity exercise. If you're done with treatment, then we go back to the National Physical Activity Guidelines of that 150 of moderate or 75 minutes of vigorous intensity. And whether you're on or off treatment, resistance training to help you keep or gain muscle, depending on the context, is so important because muscle is so important in contributing to all of the processes in our body to help maintain normal physiological function. So the goal is to engage in that whole body resistance training at least 2 days per week, whether you're on or off treatment. So here is an example of some work that we do in my group. So back to what I was telling you about earlier, the CORE trial, the one in breast cancer. CORE stands for Comprehensive Oncology Rehabilitation and Exercise. Here's the clinical trials number on the slide. And then that first paper for feasibility and acceptability that was presented, that is published now in the American Cancer Society's journal, Cancer. And so first, before I dive into this study, I just quickly want to touch on the difference between rehab and exercise. It's a nuance here that's really important. Both professions have complementary skills. And sometimes folks need one versus the other or both at the same time. The ultimate goal of rehab is to correct functional deficits like mobility issues. Whereas an exercise physiologist, our goal is to improve fitness, performance, and also do some research to understand what those mechanisms are that are related to the benefits of exercise. So that's the bottom line of the differences between professions. And throughout the care continuum, needs can change. And so here's the problem we're trying to solve in this study. We know that needs can change throughout the care continuum, but when do you make the decision to refer to rehab or exercise or both? And how do you get that into clinical care? So the aims of our trial were to look at feasibility and acceptability of this algorithm, which I'll show you on the next slide. And then we wanted to get some data to see how effective is this algorithm on improving exercise engagement, keeping people exercising throughout treatment, and function and quality of life. So here's what that algorithm looks like. So every time, so this trial is in women newly diagnosed stage 1 to 3 breast cancer with surgery as first-line treatment. So every time they come in for a clinic appointment, we hand folks an iPad. They complete 2 short questionnaires, 12 questions total, and then the results from those questionnaires tell the patient, okay, exercise self-management, which is keep doing what you're doing, you're exercising, you have no functional issues reported, or do you need our clinical exercise service, or do you need PM&R, physical medicine and rehab, or the rehab service? And then the rest of these boxes kind of walk us through what's next after the exercise service. Do you transition to self-management? Do you also need rehab, and so forth? And the ultimate goal is to get people transitioning to self-management or exercising independently on their own. So here's that design of the trial. As I told you, stage 1 to 3, newly diagnosed, plans with surgery as first-line treatment. So we randomized 2-to-1 to core or standard of care, and then these are the 3 standard of care visits. So we aligned this trial to go with folks' standard of care visits with their breast surgical oncologist to attenuate burden of being in the trial. Here's the picture of that algorithm again, that triaging tool I was telling you about, the 12 questions. It's an 8-question questionnaire about function, and then 4 easy questions about how much exercise are you doing right now. And based on the literature and evidence available, we developed this scoring system that you see in the table here. So with that PROMIS or physical function questionnaire, based on that score, plus whether you're meeting guidelines as reported on the leisure time activity questionnaire, that would tell us, okay, this person needs the exercise service, needs rehab, or can just keep doing what they're doing. So that's the magic that was happening on the back end, where after the patient completed the 12 questions, boom, they got a result for what they needed. And then we got them the referral to get them the right service at the right time throughout their care. So on the right-hand side, this is just the study design in a different way, just to remind you of the time points, the standard of care visits. The left-hand side, this table just shows you what we measured when. So for feasibility, we wanted to look at how often did people actually complete this triaging tool when they came into clinic, and then did they actually do the referral if they had a referral to complete. For acceptability, we did focus groups with everyone at the end of the 24-week intervention. And then while folks were in clinic for these standard of care visits, we did these physical function tests. We gave them an iPad to complete 2 questionnaires, a function questionnaire and a quality of life questionnaire. We also gave them this watch. It's called an accelerometer, and it measures activity. It's kind of like a Fitbit, but more there's more fancy stuff in it to help us really understand when you're sitting versus standing, how you're moving, when you're moving, how quickly you're moving. It's called an accelerometer. So we gave that device to folks. It looks like an Apple Watch. And we said, wear this for a week and then mail it back to us. And we gave them the envelope to do that. So we approached 334 people. We enrolled 72. For feasibility, we had 40 in the core group, 21 for standard of care. Acceptability, we had 15 people who elected to do focus groups. We had 61 people in the analysis because, again, 11 were what we call screen fails, or folks who we thought they needed surgery first, and then after we screened them, while we were screening them to enroll them in the trial, not so fast. Dr. Coletta and team, this person needs chemo first. So that's what a screen fail is. So then they couldn't be in the trial. But overall, we found no significant differences in clinical and demographic characteristics between core and standard of care. The median age was 58 with a BMI of 26, which is overweight classification. And our women in this trial were primarily white, non-Hispanic with stage 1 breast cancer. And most women received 2 treatment regimens after their surgery. And what we found was that our trial was feasible. So our metric for feasibility was we wanted at least 66% of people to complete the triaging tool. We got 93% of people who actually did it when they came in to check in. We wanted at least 50% of people to complete referrals if they were given a referral. 62% completed their referral. Overall, for acceptability, we have really rich qualitative data about the trial, but if I had to quantify that qualitative data, we wanted at least 50% of the themes identified, or the subtopics within the topics of our interview guide for the focus groups to be positive. And we had about 75% positive feedback in terms of how people felt about the program. 100% everyone had positive outcomes and reported feeling better, having exercise and rehab as part of their routine care, and then 50% for positive feedback for improvements. And just quickly, some preliminary estimates. So we're still analyzing and interpreting the other outcome data. The sample size is small because we were powered to look at feasibility and acceptability, because now we want to do a bigger, larger trial that's for everyone who's newly diagnosed with breast cancer, with the dream of this being for everyone diagnosed with cancer. But here's what we found. We found that for exercise engagement, folks in the core group, generally that's the teal versus orange, they did better and exercised more throughout their care. We saw better data to support an improvement between pre-surgery and post-surgery versus pre-surgery to 24 weeks post-surgery. And then in terms of the accelerometer data, or that objective measurement of function, because this data in the figure is from the questionnaire, we found a modest increase in exercise that was actually measured from that fancy watch in the core group, and a modest decrease of 10 minutes for the standard of care group. Our function results, and I misspoke on the last slide about activity here. I meant to talk about function, such that function was better pre-surgery to post-surgery, but not pre-surgery to 24 weeks for core versus standard of care. But we're still analyzing and interpreting these results. So we've got a little bit more to do here to really understand what we're seeing. But overall, we think that this algorithm was feasible. We had overwhelmingly positive information from the acceptability results. And so we think that this is still worth continuing on to see if we can really improve outcomes and eventually survival. So with that, I'd acknowledge our giant team to get this trial up and running. It takes a village to run these trials. And I thank you for your time and attention. Last thing, I'll stop sharing. If you are thinking, well, we don't have an exercise or rehab service at our institution, so what does that mean for us, Adriana? Well, let me share in the chat here this link to the American College of Sports Medicine's Moving Through Cancer initiative, and take some time to peruse around this site. And what you will find is a program directory of rehab and exercise services across the world. So you could eventually use our triaging tool at your institution, because we want to integrate it in the medical record. But then if you didn't have a service available, you could then say, okay, my patient needs rehab. Now let me go to ACSM in their directory to find rehab for them, or to find an exercise service. So that's how you can use this together. You'll also notice that the ACSM has a survey similar to what we're doing here. The difference is that ours is shorter and validated, and they're still working on validating theirs. I'm biased, but the ACSM tool is still a good tool, since obviously ours isn't accessible yet, as we continue to rigorously test it at our institution. So thank you for your time and attention.
Awesome. Thank you so much, Dr. Pladen and Dr. Coletta. That was a lot of great information. We do have some time for maybe 1 or 2 questions, but before we get into the Q&A, I just want to share super quick that we are planning to maybe have a follow-up webinar to this research that's focused on community organizations in the Mountain West that are doing work related to these topics. So stay tuned for those. And then I did see that Bailey put a question in the chat for Dr. Coletta. Is it safe to say that strength training that increases your heart rate could be considered aerobic exercise? And do the recommendations change based on this? So Dr. Coletta?
Oh yeah, you can get real creative with that strength training and make it like circuit training, and really get bang for your buck there, and kill 2 birds with 1 stone. I love circuit training personally, and we we like to encourage that with our folks, but we tailor our training to the person, meet them where they are. But if you're able to do that, that's a great way to save time.
Other questions open to the group?
I have a question for people that joined. Is there anyone that has any input on what they would like to see in terms of diet or exercise research for cancer patients? Or anyone that has family members that have experienced cancer?
I could just say, I lost my dad to cancer a year and a few months ago. And so a lot of the treatment, he was a patient here in Huntsman, caused like extreme fatigue, lack of interest in food, and then he also had dementia. So I do think we need to do a better job with caregivers, because in my experience with him as his primary caregiver and doctor navigator here, like no one ever talked to me about what he was eating, even though he was extremely fatigued. And with someone with dementia, I mean, they just kind of eat what they want to eat. So I could get him to eat like ice cream, but could I get him to have a salad if he wasn't in the mood for that? So I don't know how you work with people with dementia to encourage them to be more thoughtful about their diet and exercise. Like his physician would say, like, how often you're exercising? He's like, oh, every day, but he would completely overestimate his activity levels too. So then I think maybe the caregiver needs more support in trying to really assess that. Or yeah.
Thanks. That's actually really good feedback.
Yeah.
And we're currently redesigning our boost study and kind of redesigning it for a couple of different cancer types, and fatigue is one of the key things that we're seeing. And part of the challenge of doing interventions is even having effort to bring the box inside from the porch. You know what I mean? So yeah, I'd love to talk to you more about it. But it sounds like, yeah, working with caregivers and really addressing the fatigue issue.
Yeah.
Sounds like a priority.
Yeah.
An interesting thought on that note, from what Deanna said, is maybe how to motivate individuals, especially while they're undergoing treatment. Of course, we all know like fatigue is a huge thing. So even like we've mentioned, just getting up off the couch, and maybe that is sufficient enough, right? Just the fact that they are just doing something little by little, maybe that has an impact as well. Same with diet. I mean, my dad also had passed away, and he just, like, the idea of food, trying to trying to ask him to eat food and to do anything with it was super super hard. And I didn't know what to do. None of us knew what to do in terms of encouraging him, or except for just forcing it down his throat basically. So anyways, recommendations, or if there's solutions to even just getting people to eat food when they don't want to.
Yep. Food as medicine. Think of it like a pill. Think about yeah, but it's much more complex than that. But yes, I think we can brainstorm some strategies, and maybe this would be something to bring to some of the patient advocate groups to talk about more and get some more ideas. I think there's a couple of, oh, Adriana, you addressed your question in the chat.
Yes.
There was an exercise question.
Great. And we are wrapping up, so I want to be respectful of everyone's time. Allison is just going to launch a quick poll for everyone to answer a few questions regarding the webinar. Dr. Coletta, Dr. Clayton, thank you so much for your time today. A lot of great information. And I'll be mindful of what kind of coffee bean I am drinking moving forward. So thank you so much. If there are other questions, feel free to reach out to me and I can get them to Dr. Coletta and Dr. Clayton. Thank you, everyone.